that will scale Plateau State beyond where we are at the moment. As has been presented in the past during the keynote presentation, you know that Plateau State at the moment stands above the national average regarding the coverage of health insurance. I think we stand on about 10 or 12 in Nigeria. However, when we implement this program, and of course with the support of the Association of Public Health Physicians of Nigeria, we estimate that we'll be the first in Nigeria because we could see very clearly from the preliminary data that we have that there's a lot that can be done with efficient allocation of resources in Plateau State. So essentially, that's what we've been doing, that's what we have achieved, and that's what the vision actually looks like for the future.
Thank you very much. That was very, very brilliant. And I see that you've done so much. And I love the innovation in that you're bringing in to ensure that people are actually covered. I got worried when we talked about 10% and we were celebrating 10%. Yes, I know that when we compare with others, we should celebrate it. But if we want to look at the targets, what we should reach, I mean, 10% should not really be what we should be celebrating. So for me, I think that, well, I'm not too sure, but it appears there are still some challenges having to reach people with all this package that the government really has put in place. Can you like tell us what challenges you have reaching to the people, the hard to reach, the vulnerable you have already mentioned? And can you kindly just let us know, do you have issues of still lack of awareness or issue of trust? And how are you dealing with that?
All right. Thank you very much. I'm actually I like your initial position about uh, the need for us not to really celebrate the 10% of our achievement, but it will also be important to look at that in the light of where we're coming from. If you look at the national level, the National Health Insurance came into life around 2025. And between that period to when we took our baseline assessment in Plateau State, we realized that only barely about 2 point something percent of Plateau residents were covered with health insurance. And if you see that between 2021, when we commenced enrollment to now, we have jacked up the enrollment to over 10%. That means that the future really looks very, very bright. And some of the things that we've talked about is the innovation in utilizing equity funding. Now, again, go straight to what you've just asked about the challenges that we are experiencing at the agency. Yes, I agree with you totally that there is a gap or deficiency of awareness among the people. Beyond just the deficiency of awareness, there's also the deficiency of understanding what health insurance really is. There are people who have known about health insurance, but are unable to key in. Of course, that can simply be explained by the behavioral economics that really follow uptake of health insurance. Generally, within the Nigerian setting and looking at our culture, people are generally poor. Now, the 2022 Multidimensional Poverty Index Assessment defines Plateau State as being one of the top 10 in terms of poverty. And some of the indicators that were used include health. And in health, they looked at access to healthcare, food and all those things. So if you see a typical man on the street who has deficiency of funding, and they want to buy food, number one, which is present, and they want to buy health insurance whose benefit is in the future, people want to employ what is called present bias and discount the future benefit of health insurance. So we have a great role, to educate the people of Plateau State, not just to know that health insurance exists, but to bring forward some of those things, the benefits in the future, to the present, so that people will understand that health insurance is an investment you make now, so that you can benefit in the future. Now, how do we also do that? You would see over the social media that past 2 days or so, we were in Abuja to see the Minister of Humanitarian Affairs and Poverty Reduction, who incidentally also happens to be a son of Plateau. Those are some of the ideas that we're utilizing. We're identifying stakeholders, people who hold either position or have resources that can contribute by adopting people in their communities so that they can also benefit from health insurance. Also, you see, tomorrow we'll be having a meeting with a group of people that the Darkum Foundation actually paid premium for them. So they paid premium for 100 people, and the like. So we have pockets of people like that that we identify who can buy premiums of health insurance for individuals either in their communities or across the state so that they can actually benefit from what we do, at the agency. That's number one. At the national level, there's also the issue of portability of health insurance, the fact that you register for health insurance in Plateau State. One of the challenges that we had then, people will say, if I register in Plateau State and I travel to another state, will I be able to access healthcare? Now, what we're doing at the moment at the national level is that there's the portability of health insurance so that you register in Plateau, so you travel to another state, you also be able to access care. That will really bring the benefits to the people who already enrolled. So number one is the shortage of funding for coverage of people. Number two is a lack of awareness. Number three is a lack of, although there's awareness, but the understanding of how health insurance actually works. And number four, of course, is the desire to reach the target population. And I'd like to also call on Association of Physicians of Nigeria, if you're able to identify anyone within the state or even outside, people in diaspora, who can contribute by buying premium to specific group of people in the state, we're open to reaching out to them as well. Another major issue again that we're experiencing is the issue of quality of care that our enrollees keep complaining about when they go to access care. Although a lot of efforts and investment is being done in that regard, but it still remains a major issue that our enrollees go to the facilities and they are unable to be seen in a timely fashion, and that when they are being seen, they are unable to gain access to the commodities that they need to keep them to satisfy the full spectrum of quality in terms of safety, in terms of effectiveness, in terms of humanity, and in terms of also equity. So it therefore means that we need to continue to work with other government agencies. My brother here, the Drug and Medical Commodities Management Agency, has been doing a lot, and we hope to continue to collaborate in that regard to strengthen the supply of commodities as well as consumables that are germane to the delivery of quality healthcare to our enrollees. And I'm also very excited about the employment of human resource at the primary healthcare level, so that when our enrollees go to the facility, they'll be able to see the right person who will be able to make the right diagnosis, make the right prescription for them to remain in optimal state of health. So essentially, those are some of the challenges that we're experiencing. And of course, those are some of the modalities that we're also utilizing to overcome the challenges that we experience at the agency. Thank you.
Thank you very much, DG, for enlightening us. I think from here we can take it up. More people should be more aware, and we should be able to build more trust around there. While you were discussing, you talked about having essential commodities, and not just having the essential commodities, but quality essential commodities. And we know that it is very critical, when we talk about universal health coverage. Please, Pharmacist Kim, can you just tell us what your agency is doing to ensure availability, out of stock, and the quality of this essential medicine?
All right. Thank you so much for this very beautiful opportunity. I'm going to speak as the baby of the agency of the Ministry of Health. The agency was established and signed into law on the 27th of October, 2022, and my predecessor was appointed thereafter. Now to where we are today. We picked up our functions basically from the section 4, subsection 1 to 7, establishing the law, the agency, and we designed and compressed everything to a 4-pillar strategic initiative. And those strategic initiatives are focused basically on: 1, ensuring availability of essential medicines and medical commodities. Number 2 is reducing as much as possible out-of-pocket expenses for our patients. And then number 3, very importantly, is to harness resources possible to ensure safe warehousing and equitable distribution of commodities across the entire state. And then number 4 is to be accountable for everything that we do at each point of implementing our tasks. Now, coming on board, there were a lot of things we saw, just like my brother said. For every single patient, to be realistic, For every single patient who leaves his home and feels unwell, actually desires to get to basically 3 points. Number one, the person is aware that there is an infrastructure somewhere or a building where he or she can access care. The second very important thing is there is a personnel or there's a professional somewhere that will give him the very right diagnosis, and of course provide all the necessary issues around care. And then the third very important thing is there is a product that will be given to him or her for the person to feel well. Now, if you gauge the three, you will see that we are trying to build our initiatives, working together as the Primary Healthcare Development Agency, plus CHEMA, and then the DMA, in ensuring that we meet these very gaps and hold the loose ends, as it were. Now, when we came, we realized that there was a need to, first of all, establish the fact that we are the only source of medicines and commodities that are safe, effective, and very qualitative across the state. And what did we do? We decided to say, okay, let's proceed to ensure we identify or we do a mapping of our existing health facilities, one. Two, to also carry out a mapping of our manufacturers that have been duly licensed and registered by NAFDAC. And we've identified that we have only 3 in Plateau State, although one is currently shut down. We only have 2, and they have a limited number of commodities that they manufacture here in state. And then we also have within the country about 114, and then outside the country that we can work with, we have about 22. So we mapped all of them, engaged them, had a discussion with them, and signed MOUs with a few of them to provide us supplies directly to the agency. Now, we didn't dwell on the existing structure of having a middleman, because a middleman will definitely increase the price of those commodities and those medications. It may not sound very good for some who have been in business, but I tell you, it has given us more results, because upon removing those middlemen, we got prices of our medications and commodities dropped by over 50% here in Plateau State, because the data is already showing, and we already have an existing structure that is indicating that there is affordability of healthcare across Plateau State. Number two, one of our major functions in section 2 of that law, subsection 2 of that law, is to map and to curb all forms of adverse drug reactions. What did we do? We immediately swung into action by establishing a drug information center for the state, where we have a dedicated line that can be called all over to find out. And currently in the database, there are people who have reported that they have had adverse drug reactions from medications they got either from the hospitals or from even private health facilities. We didn't limit it only to public health facilities. We also said you could also report if you purchase any medication from private outfits. And guess what? We realized that reports that were coming in, over 50% of them were coming from herbal mixtures that were not standardized. Where do they get those from? No wonder we're having a lot of diagnoses related to kidney failures and so on and so forth. And then also we had a number of them, about 31 to 32% from self-medication. What happened to accessing care at the health facilities? And then we also have a few from recommendation, where people recommend medications for them to take. So the Drug Information Center is robust, and we have an inventory system that actually keeps and steers the data for the number of years we will live and even when we will outlive. And then the third function, very importantly, is to go into local manufacturing. As a state, we have just run our abilities to go into local manufacturing. God bless J.D. Gomwok, God bless J.D. Jang. The two of them came up, initially commenced by the former governor J.D. Gomwok, that commenced or that ensured the places of local manufacturing, little syrups, suspensions, reconstitutions of medications that were given to the end user at the health facility. And I tell you, they were very, very affordable. And J.D. Jang came and set up a mini manufacturing outlet, although it hasn't been completed yet, and we're already working on completing it to ensure that we manufacture what we use in here. You saw when the keynote address speaker was presenting on the resources that were put in during the COVID period. Honestly, pandemics are, to me, I see it as an opportunity to bring out the best in us. We must not wait for another pandemic. We must prepare for ourselves. What does it cost me as a pharmacist to manufacture normal saline, for example? Just my knowledge, just my availability, just what I need to do. And we are already working on that to ensure we put that on ground. Now, we had signed those MOUs, and one of the companies we signed MOUs with is for them to come into the state to provide this manufacturing edifice, and then we take over from there after some time. What are we supposed to do as government? We provided a plot of land. We've procured over 5 hectares of land for that company to come. We've also ensured that we give them a tax waiver, and His Excellency have graciously approved that, so that as soon as they come in, we go ahead and proceed with those local manufacturing and see how best our people can benefit from that. We have therefore also ensured quality and safety of medications by providing a pharma-grade warehouse that meets international standard of storage and was duly commissioned on the 10th of September 2024 by His Excellency the Executive Governor of Plateau State, by Sir Caleb Manasseh Mutfwang, and he did that with very critical operational items in the warehouse. We have an existing cold room that works, that ensures our vaccines are safe and maintain the particular quality that have been duly made to attain. And then we are also planning currently to ensure that the other warehouse that is fully solarized be commissioned very soon. And we've also come up with a supply chain fleet where our medications are supplied in a timely manner across the state. Because when we came, we discovered that there's a lag in the time of supply. Okay, what we call a lead time was becoming too long, and we didn't like it. And then what about the storage condition? So we currently, His Excellency has procured for us a cooling van, a vehicle that has all the necessary conditions for medications to be delivered safely to the doorsteps of the health facility. In addition to that, there are also other components of the fleet that will be commissioned very soon for onward deliveries to every primary healthcare. And then there are also innovative things we do. Finally, we came up with an inventory system that for every single tablet that comes from a prescription that a doctor writes, every single tablet must be accounted for by the pharmacist. So we've created a system for end-to-end visibility from the health facility down or up here to the agency. We therefore designed a local tool, and that local inventory tool is called the PLA supply. We named it the PLA supply. PLA means plateau, and then supply means the inventory end. And so it provides us with a system where first we know the list of our manufacturers, secondly we know the list of our health facilities, thirdly we know also the list of those who we work with as an agency, the medications, the commodities, and everything that has ever come into that agency and out to the health facility has been duly captured. And gladly again, at the dashboard, it tells us what is less than, for example, 100 left, and we need to restock. Number two, it also gives us an idea at about 25% reorder level. Number three, it also gives us a 6 months warning of expiration, so that it will minimize wastages of commodities, it will minimize losses of commodities. And then, sadly, I'll tell you, Ma, and everyone, I took over and I met commodities that were lying expired of over 200 million. That day I cried. And I told myself that, is it not the same Plateau State that had IDP camps? You heard what the DG plus Shema is saying. Those are vulnerable set of people. What stopped us from ensuring that those commodities are given to them? At least, even if whatever it is, even if it's just for them to pray for us, okay, we'll be happy. But as it is, we are not going to allow that to happen. We will ensure that no single medication expire. We will give them out as at when due. And we had come up with a system where we track this. Apart from the inventory system, we do an internal meeting every single morning by 8:30. If you come to the agency, you will see every single staff from myself down to the security man standing in to report the functionality of what we do and what happens to our warehouse, what's the temperature, what's the humidity, everything that concerns the quality and safety of medications. We ensure we do that. And that's why NAFDAC actually scored us 63% in Plateau State for a drop in circulation of substandard medications. Thank you.
Did I open? Okay. This is awesome. I hope that this will be sustained. While you were talking, before this last statement, I was just going to ask you about the security of the drugs, but you have just answered the question. And you also talked about partnership. So that would take me quickly to look at our implementing partners. Dr. Victor, can you just please let us know how you assess the impact of partner How would you assess the impact of partner-supported program on achieving this universal health coverage in the Plateau? What's your experience?
Well, thank you very much, Professor, for giving me this privilege. It's a beautiful question. But before I start, permit me to bring greetings from my boss, Dr. Solomon Wekbe, who is supposed to be here. I'm actually standing in for him. He's unavoidably absent. And permit me also to talk about the agency I represent. Yes, I work with APIN Public Health Initiative. I want to be a little jealous. It was not mentioned during the keynote address and the rest of them, but I want to just educate us a little about what we do in Plateau State. So we are an indigenous NGO, provide care and treatment for people who are living with HIV and AIDS. Might interest you to know that in Plateau State, we provide treatment to over 49,000 persons in Plateau State. And these are mostly indigenous of Plateau State. Yes, so we are doing a great deal in Plateau State. And I think next time when we're mentioning partners, we should talk about APIN Public Health Initiative. Yes. And again, we're also providing programming in tuberculosis and, of course, maternal and child health in the form of prevention of mother-to-child transmission of HIV. In Plateau State, we are actually operating in 17 local governments. And so that means we are in all the local governments in Plateau State. Yes. So, yes. A lot of work has been done, but I can tell you that still more is yet to be done. Because every week we find almost 50 positives. 50 positives.
You mean new cases?
New cases. 50 positives. And I can tell you that this is because of a lot of awareness that is going on. You know, so many people are now becoming more aware and people are coming out to get tested. Before now, people are not aware that there is treatment free of charge, actually. And so, because of a lot of work that is going on at the community level, people are now coming out, agreeing to be tested. And of course, it is important that we all get tested. So, coming to the question proper now, accessing the impact of what is happening to universal healthcare. I will look at it from the pillars: quality, access, and then no financial burden. You know, if you look at what we do, we principally work with stakeholders. And of course, for you to get stakeholders on your side, you must ensure that whatever you're bringing is interesting to them and beneficial to them, of course. And so I can tell you that the Ministry of Health has been a very strategic partner to APIN's program. And we have enjoyed critical partnership with them. At the facilities, we have supported access because we are now in every local government. Before now, we are in about 14, but recently last 2 years, we activated more sites in Wase, that's the FMC in Wase, and then we also activated the hospital here in Riom, and of course, we activated the General Hospital in Kanke, and so that completed it 17. So we are promoting access, and these are actually secondary healthcare facilities, and we have a partnership also with tertiary health facilities. I think you're aware that we work with youth. We work with Bingham.
The CMD is here.
Yes. We also work with Plateau State Specialist Hospital, Ola Hospital, Bingham Hospital. So these are tertiary hospitals that we are also working with. Interestingly, we are also present at primary health care facilities in the rural areas. So sometimes you see us with our jean and face cap. We're traversing the rough terrains of Plateau State, trying to reach the unreachable with healthcare services. And this is actually promoting access to healthcare. And talking about the quality of healthcare, we work with our stakeholders to achieve quality healthcare because we work with data. We use data to promote strategic decision making. And so this actually promotes the quality of healthcare. We don't just supply medication to the facilities, supply test kits, and then we leave them to do what they want. No, we monitor them, and of course, we continually train them so that they are providing quality health services at the facilities. And I must tell you, Professor Invilado, that we also equip laboratories. Yes, recently we distributed some equipment. I think the Honorable Commissioner was there. We distributed equipment to facilities. In fact, he attested the fact that it's the first time he is actually noticing, experiencing that. Of course, but most of the facilities we work with, we equip their laboratories to make sure that the result that comes out from those laboratories are quality results, and that is in the aspect of quality. And of course, we also support training of healthcare workers. Yes, and in Plateau State, interestingly, we have over 400 ad hocs that we have employed that are under the payroll of APIN that are supporting over 40 facilities in Plateau State. Now, these over 400 ad hocs are continuously trained to ensure that they have the up-to-date knowledge of providing care and treatment for people who are living with HIV and AIDS. And I can also tell you that every Thursday, we have a 1 hour session, 1 hour session across all the facilities, including Ministry of Health. What we call, before now we call it tele-eco session, but now it's SPICE teleconferencing session. And NASCAP is actually anchoring this training session. Every week, select subject matter experts, develop teams in critical areas of HIV management, and this is presented and broadcasted through teleconferencing mediums like Teams or Zoom technology. And these facilities have been installed with teleconferencing equipment like televisions, systems, cameras, and of course, they are provided with data stipends on a monthly basis to allow them access these meetings and get the required training. So all of this promotes training and promote quality health delivery. And so I can tell you that these interactions have actually promoted a lot in Plateau State. And under the leadership of the current Commissioner for Health in Plateau State, we have seen tremendous improvement in actually supporting healthcare health activities. I remember just recently we had a review meeting, and all of our stakeholders were there, including the DG of Plastchema. Interestingly, because of those engagements, for the very first time, I heard about Mutwan Care, and I was so excited. And he even made promises that if we have 10,000 people who are living with HIV and AIDS who are classified as vulnerable, we should bring them. They will be enrolled in Plastchema. I think that shows tremendous commitment of this administration to quality and access to healthcare. And that shows that we have visionary leaders at the right places to engineer this. I mean, you can listen to what Pharmacist Kim is talking about. So these interactions have actually promoted universal healthcare.
Thank you very much. Thank you so very much. You've said so much, and across the board, while the discussion was going on, you see the issue the issue of data coming up over and over again. If we do have time, I would take another question, especially with partners and stakeholders. But then let's look at the academia. With a lot of data coming up and research, I'm sure the academia are the backbone of what should be driving evidence and decision making. Professor Chingle, please. How do you think that research and data can better be integrated into policy and implementation of all the programs that we're looking at right now?
Thank you very much to the anchor. I was wondering when it will come to my turn. I must say, my being here today has.
Yes, because you seem to be the backbone and the foundation, yes, the masquerade. That's why I left you to the end. Not exactly the end, anyway.
Okay, thank you. I must say, my eyes have been opened with the lecture that we just had and with the contributions of the various panelists here. I must say that the state government and the partners are doing quite a lot, and it's really encouraging for me as a citizen in Plateau State. And definitely as the academia, we have a role, and that is why in all the engagements that we have, if we're invited, we always make ourselves available to share our experience and also give the government and the partners our view on issues. It's very, very important that at all times, data is collected in the course of the discharge of our duties. And we always do that. It's not a problem. Almost every unit you go to, as they are discharging their duties, they are collecting information. But the major issue is that a lot of those informations end up on shelves. We don't utilize them, in driving policy. We don't use them as evidence in order to drive our decision making, which is unfortunate. So one of the major things that we can do is, apart from strengthening those data collection systems, we must put measures on ground to ensure that periodically that data is being looked at and then analyzed so that it can guide us. It will give us an impression of how well we are doing. And then if we're on track, definitely we pat ourselves on the shoulder and we continue that way. If we are not on path, we are drilling in one way or the other, then we can retrace our steps and look at what we are not doing rightly, and then we can correct it. The country has a data repository, which is a DHIS2, and almost every information is fed into that. And ideally, depending on where we are working, we are supposed to be feeding this information at the end of the month and things like that. Anytime I go to health facilities, I want to see